I'm very excited to introduce Jean Lamantia, our speaker for today. So Jean is a registered dietitian, a cancer survivor, and the co-author of the Complete Lymphedema Management and Nutrition Guide. She has a virtual private practice where she helps cancer patients and survivors to use food to meet their nutrition and health goals. And you can read her Cancer Bites blog and learn more about Jean on her website at www.jeanlamantia.com. So I think with that bio, I'm very excited to introduce Jean to present our content for today.
Hello, can you hear me?
Yes, I can hear you perfectly.
Okay, and I think you can see me now too.
Yes,
hello, everyone.
perfect.
Welcome. And I'm just going to get right to it. And thank you to Wellspring and to the Ontario Lymphedema Network for inviting me to speak. I think I said that wrong. Lymph Ontario. Well, Tony will correct me at the end. Sorry, Tony. All right, let's talk about nutritional management of lymphedema. And before I get into my talk, I do want to say that I have some disclosures. I have written 3 books, one which is specifically co-authored on lymphedema. One is a cancer book designed for people who are in cancer, and my newest book, which is just on pre-sale, is on intermittent fasting, and then I have a guide. So those are my disclosures. I do earn small royalty from the sale of those items. Now, when I first started looking into this field, and actually the way I got into this was from Anne Demena, the previous week's speaker. And as you know, if you were on that call, she's a physical therapist that specializes in helping people with lymphedema. And she got in touch with me knowing that I have a strong background in cancer nutrition, and because many of her clients were dealing with lymphedema after cancer. And I said, absolutely, I would help her and I would help her clients. And what I discovered is that, you know, when I started poking around and figuring out what's available, this is the kind of information I got back, which was, you know, there isn't enough research to give any type of diet advice to people with lymphedema. And then I'd be in the clinic and I'd see a client and they'd say, well, is there anything I can do where you can help me with my lymphedema? And I really felt like, right in the middle of these two. Yes, I want to respect the science and the process, and I don't want to be just giving out information that I'm making up. But yet at the same time, I can't say to someone who's in front of me, well, there isn't enough research to give you any advice. How does that help them? So, and I put that out there because I want to be fully transparent about where the information comes from. You know, as someone with lymphedema, you're probably aware that it doesn't get the attention that it deserves in the medical community. Well, no surprise, probably it doesn't get the same attention in the research community either. So when I'm giving you recommendations about diet, I want to be totally transparent and I want to be totally respectful of that that image there on that cartoon that wants the information I give to be sound and to be evidence-based. So my first category is my recommendations are evidence-informed. Secondly, it's based on the current standard of care. There were already recommendations well established before I got involved in the lymphedema community that relate to nutrition, so I'll share those with you. And then just me hypothesizing based on how does lymphedema work, what's the physiology of it, and what actually would make sense, and what have I seen with my clients. Okay, now all of the research that I'm going to talk to you about, if you are the type of person who likes to read the research, I've made it super simple for you because I wrote a blog post and it's called Lymphedema Diet. So you can either go to my website and look for the blog, or just type into Google Lymphedema Diet and you'll see the blog post. And then when you're in the blog post, I have links to all the research. It's hyperlinked. So if you want to read the study about weight loss, you click on it, it'll take you to that. If you want to read the one on low-fat diet, click on it, it'll take you to it. So I've made it super simple. All right, so this is my agenda. So what is the information based on research? Well, that's around weight loss as a prevention and as a treatment, and on low-fat diet. Then I'm going to talk about fluid, protein, and sodium. And then I'm going to talk about some ideas that I have that I've seen that make sense to me: time-restricted feeding, regular bowel routine, and an anti-inflammatory diet. All right, so let's talk first of all about weight as a prevention. And just going to move this little square here. Okay, so what we see here on this chart is, you know, the first name of the author who wrote the study and the year it was published. So it all goes back to 1957. And it looks like I didn't put the years in order, but up to 2016. And basically, so there's some studies that were on obese people, for example, but a lot of it, if you just scan down here, a lot of it was done on the cancer community. And the big question in these researchers' minds was, well, when I treat this person with breast cancer, this person with endometrial cancer, this person with melanoma, some of my clients have lymphedema at the end and some don't. What's the difference? How do I know who's going to get lymphedema and who doesn't? So that was the purpose of these studies. And what I've summarized here in the results is only what they found related to nutrition. So there were other things like the amount of radiation they got was predictive. Whether they got radiation, the amount of lymph nodes they removed, whether they had sentinel node biopsy. But what I'm focused on here is just the nutrition. And what I see over and over again is that if the person is obese, and you know, I apologize for even using that word, but this is the word that they use in the research. And I don't like to label people with that, but anyway, I just want to put that out there. Or they use the BMI. And what do you find if you scan down here? So obesity is a predisposing factor. A BMI of 54 or more showed lower leg lymphedema. A BMI of 26 or more, a higher BMI, a higher waist to hip circumference, BMI of 25, etc. So they're all showing that risk, except the two that I've highlighted, and I want to talk about those. So in this particular study with 787 breast cancer patients, if they had a BMI of 30 or more before treatment, they were at greater risk of developing lymphedema. If they had a 10-pound weight gain during that, I think kind of sort of diagnosis and treatment stage, then they were at greater risk. What is interesting, which is why I've highlighted because it's an outlier, is that if they lost 10 pounds, and the researchers went on to say, well, why could that be? Perhaps it's if you lose weight quickly, you have space underneath the skin because the skin doesn't tighten, you know, right away, especially if you're older, it doesn't tighten up right away, which leaves this kind of vacuum, and then that space got filled by lymphedema fluid. That was the theory. But remember that because I'm going to show you a study in a few slides that also found a similar kind of idea. And in this, the 2015 one, obesity, diabetes, and high blood pressure were not found to be risk factors. I don't know why that is, but you know, we've got several other studies that show that it is a risk factor and only one that doesn't. So, but I just, you know, for full disclosure, I'm putting that on there. Okay, so that is body weight as a predictor, as a risk factor for developing lymphedema. So I'm going to assume that some of you that are joining us don't have lymphedema, but you've heard of it, you're trying to get educated, maybe you've had lymph nodes removed, maybe you had lymph nodes included in the radiation field. So first of all, I say good for you. But that information really is talking about how you can prevent the development of lymphedema. And I'm sure Anne talked last week about looking after your skin and proper skin care and all the great things from a physical therapy standpoint you can do. And now from a nutrition standpoint, keeping your body weight in check can be helpful. So let me tell you now about 4 studies that looked at, well, let's use weight loss as a treatment. Let's see if that will help for people who already have lymphedema. So this is a study done over in England. It was 21 women with breast cancer lymphedema, and they had 21 people and they split them in half. So half got what's called the weight loss group and the other half got the control group. For the control group, they said, just don't change what you're eating. I might have given them a pamphlet or something like that, but no change. And the weight loss group was eating about 1,000 to 1,200 calories a day. And then they followed these diets for 12 weeks or 3 months. And the results were, so in the supposed weight loss group, well, they did in fact lose weight, anywhere between kind of 2 pounds and 13 pounds, and the control group did not lose weight, which is good because that's what these researchers wanted. And then what they do is they measure something called excess arm volume. So in this study, they used women who had lymphedema only in one arm, and this was intentional. And so what they could do is they measure the arm without lymphedema and see how much it changes. Because of course, as you know, if you lose weight, everything goes down. And then they measured the arm with lymphedema, and they calculated the difference. And that difference is called excess arm volume. And so what they then can say is, well, if we subtract what they lost in the normal arm, then we know what's gone from the lymphedema arm is actually lymphedema fluid. So the weight loss group lost 350 mLs of lymphedema fluid, which I demonstrated there with my green dyed water. And the control group lost 11 mLs, which is like 2 teaspoons. So it really did allow them to lose lymphedema fluid. The second study by the same researchers, this time it's 51 women, they had 3 groups. So a weight loss group, same as before, a low-fat group, and then a control group. And this study was 6 months. And again, they looked at excess arm volume. But what happened with this group was interesting, is that people did not lose weight as they expected. So they wanted people in the weight loss group to lose weight. They did not want people in the low-fat group or the control group to lose weight. But what happened is some of them did. And then some people in the weight loss group who they wanted to lose weight did not. And so when you got the results and you looked at it by group, there was no pattern. So they couldn't say, for example, everyone in the weight loss group lost more lymphedema than the other two. No. So because that didn't happen that way, they said, well, let's just look at who lost weight and who didn't. Doesn't matter what group they got put into, whether they were in the low-fat group or the control group. Let's just see. And when they looked at the statistics that way, yeah, then they saw the difference. So then they saw a significant difference between those that lost weight and those that didn't, despite whatever group they were in. So no matter how they lost the weight, they got that benefit. Weight loss study number 3. So I was actually at the National Lymphedema Network conference in Boston last year when the researcher who did this study presented it. And so it was 251 women with breast cancer related lymphedema, and they had 4 different treatment groups. One was the control group. So they had to go to a facility to do exercise and weight loss. The second group got a home-based exercise program, so they had someone coming to the home to help them. The third group had Nutrisystem, a home-based nutrition program. So Nutrisystem is one of these diet programs where you drink these shakes. They did that for 20 weeks and then continued with weight loss diet after that. And then group 4 did both the nutrition program and the exercise program. They lost 8% of body weight, which is excellent. That's an excellent result in either the group that did the diet or the diet and exercise. No improvement in lymphedema. That was the big shocker, because based on those previous studies which were published earlier, this researcher thought, oh my God, I'm just going to go hardcore with the weight loss, get these people losing weight, which they did. They lost 8%, but then they didn't see the loss of lymphedema. Now, the researchers said, why? Because this was not what we expected. They said, perhaps the exercise changed the arms in a way that made measuring the amount of lymphedema difficult to do accurately. So maybe, now they had more muscle, whatever. But what this study makes me think about is maybe they're a victim of their own success. Maybe 8% weight loss was just too fast. Because as we saw in the previous slide, if they lost 10 pounds in a month, that did not allow them to lose lymphedema. And I would imagine, and when you read this paper, they don't say how much weight they lost. They just gave the total amount. But what I suspect happened is they lost a lot of weight in the beginning on that Nutrisystem program. And perhaps, as the previous researchers postulated, was that, when you lose weight that quickly and the skin kind of doesn't come down, there's that empty volume and it got filled up by lymphatic fluid. So my bottom line on this is yes, weight loss would be beneficial, but not too fast. You want it to be reasonable and not like a fad diet. So weight loss study number 4 was a very small group. So 12 people, 11 women, 1 man. And it was a lifestyle modification program with weekly meetings. And it was led by an occupational therapist. And they just, this therapist let them decide, okay, this is what the ketogenic diet's all about. Who wants to do it? And 6 people said yes. 4 people said no, and then another 2 dropped out. So they met for 12 weeks. My issue with this study, and I have a whole blog post on it, which I'll show you the link at the end, is I'm not really sure that this is actually a ketogenic diet, because the instructions they gave was eat as much protein as you want. So if you know anything about a ketogenic diet, you don't eat as much protein as you want. You only eat just enough protein to meet your needs. But the majority of the calories in that diet should come from fat. So the reason I put on here no testing for ketones, no food records, was that really I'm not convinced it's a ketogenic diet or that these people are in ketosis. However, 9 people did lose weight, and the weight loss corresponded to the loss of lymphedema fluid. And the people who did this supposed ketogenic diet lost more weight. Okay, so we have 4 studies that looked at people with lymphedema losing weight. 3 of them showed that it also reduced the lymphedema. All right, now let's move on to my next topic, which is low-fat diet. Now, before I tell you about the research, I need to give you some background, tell you what's going on in the body. Okay, so this diagram is, I want to use this to demonstrate what happens when you eat your food. So, you know, of course, you eat your food, you chew it up, you swallow it, it goes down the esophagus, it goes into the stomach. And yes, some digestion does happen in the stomach. And another big job of the stomach, it's a holding chamber. So it holds onto the food, and it just drips a little bit at a time into the intestines. And then once it gets into the small intestine, that's where the food really starts to get broken down into its smallest component. Now, the smallest component for fats and oils in your diet, so if you're using olive oil or mayonnaise or, you know, fried chicken or something, body breaks it down. The smallest component is called fatty acid. And fatty acids are chains of carbon. So you've got carbon, 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 hydrogen, 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 all attached all around. So that's the chemistry of a fatty acid. Now you can categorize these fatty acids based on how long is that carbon chain. Is it short, meaning only 6 carbons? Is it medium, up to 12 carbons? Or is it long, more than 12 carbons? And the reason why this is important is because they are transported differently in the body. So the short and the medium chain fatty acids are absorbed just right here in the upper part of the small intestine. They go right into the portal vein and they're in the bloodstream. The long chain fatty acids cannot be absorbed there. They are not soluble enough. So they keep going. They keep traveling down the intestines, and they get put into something called a chylomicron, which is a fat transporter sphere. And so once they're inside the chylomicron, it goes through the lining of the small intestines. And that's what this big image here is. So it goes through the lining, and then it's met by this thing here called an lacteal. So what does the word lacteal make you think of? Probably makes you think of the words lactose, lactate, lactese. And if you speak French, the word lait or milk. And why does it have this name? It has this name because it's a milky white substance. Why is it milky white? Because it contains long chain fatty acids. So the long chain fatty acids go through the lining of the small intestine, get absorbed into this lacteal, which is a single lymphatic capillary. And it's called a lacteal, different from the other lymphatic capillaries because it's in the GI system, okay? But Anne DeMena probably told you last week, if you have 10 lymphatic capillaries side by side, it's the size of a human hair. So it's very fine. So the lacteal gets absorbed, the chylomicron gets absorbed into there. And those lacteals, as you can imagine, it's kind of like this. They have all these individual lacteals, and then they meet up with another vessel. And then that vessel goes up the trunk. So it actually comes right up here into the left subclavian vein. And that's where your long chain fatty acids enter the bloodstream. And when it's coming into the lacteal, it's in the lymphatic system. So it's the lymphatic system that has to transport those long chain fatty acids, and it takes it all the way up the trunk into the neck area. Okay, so let's talk about fats and fatty acids. All right, so this chart, you see the different types of oil: MCT, coconut, palm kernel, butter, canola, corn, flaxseed, olive, palm, safflower, sesame, sunbeam, sunflower. I know that's not all the oils, but this is just an example, so you get the idea. Okay, which fats have short chain? Only butter, 5%. Medium chain, so butter has a bit, palm kernel oil has some, coconut oil has more than half, and MCT oil, which, hang on, I'm going to tell you about. MCT stands for medium chain triglyceride. So it's a special type of oil that's 100% long chain fatty acid. And then all the other vegetable oils that we use in our diet that we know and love are 100% long chain fatty acid. Now, this is important. It doesn't mean these oils are unhealthy. So for example, olive oil. So as a cancer survivor, you know about olive oil, you know about the traditional Mediterranean diet, you know that it's anti-inflammatory, you know that it's good for cancer risk reduction. That is still 100% true. The only reason I'm even talking about the chain length of fatty acids is because of the lymphedema, okay? And when you look at this chart, you know that if you have any of these oils, even though they're some of them are healthy and anti-inflammatory, that they require the lymphatic system for transport. And I just want to say, you see two items over here. You see palm oil and you see palm kernel oil. I just want to show you the difference. So back when we used to travel and people used to go places, warm and exotic, you might have seen one of these trees, which is a palm tree. And this is the little nut. So you get palm kernel oil from this nut inside the fruit, and you get palm oil from the fleshy part on the outside. So that's the difference there. Now here's MCT oil. So how do you make MCT oil? So a manufacturer will take either coconut oil or palm kernel oil or a combination and separate the different fatty acids. Separate the long from the medium, and then put the medium in a bottle and slap a label on it that says MCT oil. Okay, so if you buy MCT oil, it's 100% medium chain triglyceride. In other words, it doesn't require the lymphatic system for transport. Okay? It could just go from the stomach into the upper part of the small intestine right into the portal vein. Okay, so let's talk about this. Now, none of the other research I'm showing you is animal. I want to briefly mention this is a mouse study. And so they gave these little mice a high-fat diet, and they showed that impaired the lymphatic vessel. So I just want to set the stage to say, why would they even come up with this idea to research this? One is because we know how the long chain fats are transported, and two is from this animal research. All right, so this is a case study. And so what they did in this case study was two women. They both had lower leg lymphedema. Now in this case, it was not related to their cancer. This was what's called primary lymphedema, which is just women who are born with a sluggish lymphatic system. And they had lymphedema in, I think, only one leg. Yes. And so they put them on a diet that was less than 20% of their calories from the diet came from fat, plus they were allowed to have MCT oil. So you can see now why I had to go through that explanation before I could tell you about this study. Okay, so patient A was also overweight. So patient A had this 20% fat diet plus MCT plus restricted some calories. So patient A lost weight. She lost 22 pounds or 11 kilos, and she reduced the perimeter of both her thighs, which, as you would expect if you lose weight. But in her thigh that had lymphedema, she lost 7 centimeters. Actually, I think she lost, yes, so she lost 7 centimeters in her thigh with lymphedema, 5 centimeters in her thigh without. So in other words, her excess loss was 2 centimeters. In patient B didn't need to lose weight. She was normal weight, but she just had this lymphedema in her leg, and she did this low-fat diet plus MCT, and she lost 3 centimeters in her thigh. Okay, this is the second study. So this is, again, a small study. 10 women, they had upper arm lymphedema following breast cancer surgery and lymph nodectomy plus radiation and chemotherapy. That might sound very familiar to some of you. So they had 2 groups. Control group, they did now the site just said physiotherapy, but I think what they meant by that was complete decongestive therapy. But whatever it was, both groups got the same thing. So there was no difference in what they received. But they were just given this bottle of oil and they said, use this as the main oil. They weren't told what it was. And it was actually corn oil. And what happened is they gained 75 mLs of lymph volume at the end of the study. And in the other group, same physiotherapy, but this time they got MCT oil and they lost 200 mLs. And they had a significant decrease in the feeling of heaviness. So they had them rate all these different things before and after the study, and feeling of heaviness was one thing that reduced as well. All right, so in terms of research, that's what there is. I'm being totally transparent about that. So there's some, the most robust is this idea of, weight loss can prevent. So if you're at risk because of your cancer treatment, then taking care of your weight can help reduce your risk of developing lymphedema. As a treatment, I showed you 4 studies. 3 of them showed that losing weight can help reduce your lymphedema. Low-fat diet, admittedly, one was a case study, one was only 10 people, but they did show benefit. Now let's move on to the current standard of care. And again, this predates my even knowing about lymphedema and getting involved. And so what I want to point out is fluid, protein, and sodium. So in the lymphedema community, if you read blogs or, talk to your lymphedema therapist, they'll tell you, do not restrict fluid, okay? They'll say, do not restrict protein, and yes, restrict sodium. Now, why protein? Why even think about that? And that's because one thing that's different between lymphatic fluid and just regular edema, so if you have swollen ankles, but it's from, let's say, your heart not working well, or your kidneys not working well, or your liver not working well, that fluid is different from lymphedema fluid. And that fluid is high protein. So sometimes people with lymphedema think, oh, if my lymphedema fluid is high protein, I should probably restrict protein and that might help. No. Don't do that. Also, if you have just regular edema, actually, I'm going to show you on the next slide here. So here's the different types of edema. So if you have edema due to congestive heart failure, kidney disease, liver disease, the standard of care is to restrict fluid. And I've had lots of clients on these restricted fluid diets where the doctor will say, only 1,200 mLs of fluid a day or 1,000 mLs, and they have to measure out how much fluid they drink. The exception is lymphedema. So this is why it's important, if you have swelling, to figure out, is this lymphedema swelling or is it not? Because this is one area where the recommendation is different. And I'll tell you about why that is in a second. With salt restriction across the board, salt is going to hold on to fluid. With protein restriction, the only time they restrict protein is in early stage kidney disease. And then diuretics, again, another reason why you need to know if your swelling is lymphedema or something else, because diuretics will help with the other edemas, but not with lymphedema. All right, and let me just back up here a second, because there's something I forgot to tell you about. Now, why do we not restrict fluid and in fact encourage fluid? One thing is, we want the lymphatics fluid to move. We want it to decongest from the area. And if you, and having lots of liquid, lots of water there helps to be able to move it. Otherwise it's just solid, right? The other thing I discovered, I was reading a paper about dehydration and what happens in the body when you get dehydrated. Well, what happens is, of course, the fluid content of the body goes down, but the fluid then shifts, and it shifts from what's called the intracellular space, which means within the cell, to the extracellular space, outside of the cell. And then it's the shrinking in size of that cell, which then sends a signal to the brain to say, I'm dehydrated, and then the brain then sends a signal to the mouth that says, tell the body you're thirsty because we need to get some water on board. But what's interesting is that shift from the intracellular to the extracellular space, because the extracellular space is where lymphedema is. So if you already have lymphedema and you get dehydrated, your body is going to shift fluid from within the cell to the lymphedema space. So you don't want that. So you want to maintain your hydration. And as you heard in that example or that pathway there, by the time you feel thirsty, the fluid has already shifted. It's already moved into the lymphedema space. All right, let's move on to the last area. So this is more hypothesis, but I've also seen it in practice. Okay, so this is from a study that I read, and this is just a quote I've pulled out. Total lymph formation in humans is approximately 1 to 4 liters a day, most of which, more than 50%, is formed in the GI tract. So I showed you that relationship between the lymphatics, so the lacteals, and the GI tract. So after you eat a meal, there is an increase in lymphatic production from the GI tract. And it's not just from transporting fats either. So then that starts thinking, well, if more than half of the fluid is formed in the GI tract, and that's formed from eating, well then let's not eat. Let's see what happens. Well, of course, that's not very practical. So thankfully there is a method that you can try out for yourself. And of course, with any of these recommendations, let me just say this here. My suggestion is don't just throw the kitchen sink at your lymphedema. Don't just start with, more fluid, less sodium, low fat diet, weight loss. I actually think, do it in a stepwise fashion. Because one thing, I have 2 goals for you. One is I want your lymphatic swelling to reduce. But the second is I want you to get to know your lymphedema and how it responds. Because I can tell you, I've seen in the clients that I work with, I have one client, for her, salt was everything. Like, it made the big difference. It helped her get out of her plateau. And for another client, for her, it was fat. And so if you just kind of throw the kitchen sink at it, you don't satisfy that second goal that I have for you, which is to get to know your lymphedema. How does it respond to various things? Okay, so here's another tool in your toolbox. So now let me just say there are different types of intermittent fasting. And one type is called time restricted feeding. And that's the type I'm suggesting could be helpful for lymphedema, not the other type, because the other type I'm a little afraid. So the other type would be something like where you fast for the entire day or 2 days in a row. And I just think, I'm not sure what might happen there with the protein depletion. And because there's no research, I'd rather be safe and just recommend this for now. So time restricted feeding, this is based on your 24-hour clock. So for example, I saw a client yesterday, post-cancer, lymphedema, overweight, and she's eating her breakfast at 6:15 in the morning, eating dinner around, 6:37, and then having a snack at 9 p.m. So my recommendation to her was to stop that nighttime snack and try and eat within a 12-hour window. So if she eats her breakfast at 6:15 a.m., I want her to finish eating her dinner, not start, finish eating her dinner by 6:15 at night, so that the body has at least enough, the same amount of time to process all of that food as it did to be taking it in. So that's called a 12-12 window. So that means you eat within a 12-hour window and then you fast within a 12-hour window. And then, that would be stage 1. So once you try that and that works for you, then you could start, shifting your day by a half an hour or an hour and say, okay, well, now I'm going to eat within an 11.5-hour eating window, and I'm going to fast in a 12.5-hour eating window, or I'm going to go 11-hour eating window, 13-hour fasting window. And you can keep just gradually shifting it. And then I just want to put this up as an example. For example, a 16-8. So if you start reading about intermittent fasting and you see these numbers, what that refers to is you eat within an 8-hour window, you fast for 16 hours. Okay, so that's what that means. And also, I want to share with you a blog that I wrote, just shows you all the research around fasting and cancer, because that's important too. I want you to be able to read about that. All right, and this is just a quote from a client. When I cut out my evening snacking, I could see that my arm was much less swollen in the morning, and that was a woman who had upper arm lymphedema after breast cancer treatment. So observe, pay attention to what you're doing. This is from another paper. In addition to feeding, which we've already talked about, lymph flow is also elevated by acute and chronic inflammation and by intestinal obstruction. So I want to talk about both of those things. I'll talk about the intestinal obstruction first. What's that? That's constipation, right? So I want you'd want to do this anyway, whether or not you have lymphedema, but I want you to try and get a regular bowel routine. The 3 things to help you get a regular bowel routine: fluid, fiber, and exercise. And if you're missing one out of those 3, it makes it more difficult. But I thought I'd share this quote with you. I have IBS-C. That means IBS, irritable bowel syndrome, constipation. And when I'm constipated, my lymphedema goes into a flare-up. My lymphedema didn't start until my IBS-C started. So this is someone with primary lymphedema, not someone who had it related to cancer. But I can tell you, I have another client also with IBS constipation who tells me the same thing. So again, pay attention to that. So if you're thinking, why is my lymphedema flared up? Why does my leg or my arm feel heavy today or tingly? Am I constipated? Let's pay attention to that. And, make sure you're doing the fluid, the fiber, and the exercise to take care of that. From that previous quote, I now have a second quote that I want to talk about related to inflammation. Currently, lymphatic biology is experiencing an enormous renewal in interest, and the importance of lymphatics in disease is gaining recognition outside of the fields of lymphedema and cancer biology to now include acute and chronic inflammation. So that's a long way of saying there's something going on with inflammation and lymphedema. So this is from a paper that I read, and let me just take you through this. So let's start up here at 12 o'clock. Lymphatic vessels are malfunctioning. Well, why are they malfunctioning in your case? It's probably due to your cancer treatment, right? Well, lymphedema then develops, and that means lymphatics fail to absorb and or transport fat, and I show you how that works, because if that lymphatic system is involved in fat transport and it's not working properly, that fat leaks out along with other lymphatic fluid. And then fat deposits are created, because wherever it leaks out, it's going to create, or wherever the fluid becomes stagnant, fatty deposits are created. Well, when you have fatty deposits, you get inflammation, because one thing I've read recently, which just kind of stuck in my mind, I never thought of it this way, but that fat is the largest endocrine organ in the body. An endocrine organ is an organ that can put out basically chemical messengers to the rest of the body. And one of the messages that it puts out is inflammation, create inflammation. So that happens, and then what happens is the structure of the lymphatic vessel is altered, because when you have a lymphatic vessel that's forming within an environment of inflammation, it doesn't form properly. Well, then guess what? Lymphatic vessels are malfunctioning, so this cycle just keeps going around and around. So how do you break out of it? Well, one way that I can suggest is an anti-inflammatory diet. Now, this is not a huge leap, because if you have had cancer, you want to be on an anti-inflammatory diet anyway. When I talk about my 3 keys to cancer risk reduction in the guide that I created, number 1 is reduce chronic inflammation. Number 2, support the immune system. Number 3, eat the foods that can act against cancer cells directly, like the nutraceuticals. Okay, so anti-inflammatory diet, you should be doing this anyway if you've had cancer. And there's a benefit, is it may also be helping your lymphedema. Okay, so the takeaways that I want to leave you with: diet and nutrition can make a difference for you and your lymphedema. I believe this, and I've seen it. And, thinking back to that little cartoon at the beginning, yes, I know the research is weak. That's what I was totally transparent about that. But I've seen it in practice that it can help. It can reduce your lymphedema. Track your diet and your lymphedema, and that can help you know how your body responds. So if any of you have ever worked with a dietitian, or if you've worked with me before one-on-one, one thing I'm going to ask you for is food records. This is our famous tool, the tool of the trade. So, I send my clients a form, and they fill in, they write down Monday, 9 o'clock, half a bagel, cream cheese, an orange, they write it all down. They give me the food record. And ideally, what I would want you to do if you have lymphedema is be measuring your lymphedema and writing down, 22 centimeters today, or 22.5. And then you can hopefully see a pattern and see, just as I said earlier, get to know your lymphedema. Gradually implementing the lymphedema nutrition strategies can help you. That's just me. I like to go slow. I like to see how things evolve, see how your body responds. I can't stop you if you want to just hit it with the kitchen sink, all this stuff. That's up to you. But that's my approach. And just as a summary, the strategies are weight loss if you're overweight, or, you know, I know that can be frustrating for people to constantly be told you need to lose weight or your weight is the big issue. If that just is not resonating for you anymore, then take a health at any weight approach, which means I'm going to be getting my fluids, reducing sodium, be getting enough protein, eating that anti-inflammatory diet, but my focus is not on my weight. My focus is on my health and healthy eating, and that's totally legit. A low-fat diet, you can try that out. You can try the MCT oil. A couple of things you should know about MCT oil. It does take some getting used to. You know, it's absorbed differently in the body, so you can't go crazy. The recommendation is maximum 7 tablespoons a day. You can't heat the oil to a very high temperature, like nothing above 320, because it has a very low smoke point. You don't have to try those two things together. You can just reduce the amount of fat in your diet. On its own, you don't necessarily have to use the MCT, but using the MCT oil without the low-fat diet, that just doesn't make sense, okay? Because the MCT doesn't have any magical properties. What it does, it just helps replace long-chain fats in the diet. Sufficient fluid, sufficient protein. So although it might be counterintuitive, you might think I'm swelling, I need to cut back on my fluid, don't do it. Or you might think, oh, my lymphatic fluid has protein in it, I should cut back on my protein. Again, don't do it. Salt restriction, though, is okay. The biggest thing with salt restriction is if you're cooking from scratch, you're making foods at home, you're automatically on a low sodium diet. If you're buying processed foods, prepared food, takeout food, supermarket prepared food, you're getting a higher salt diet. Time restricted feeding, at least start with the 12-12. Unless there's some reason, and there might be a reason why you can't do it. For example, if you're underweight and you need to gain weight, you may need to be eating a nighttime snack to help you put on that weight. A regular bowel routine and an anti-inflammatory diet. Work with a dietitian to help you implement it. I'd be happy to do that if you want to work with me. I'm having a virtual practice now, and track your intake and your lymphedema. If you want more information, here are some resources that you can look at that cover some of the topics we talked about. Here also are some free resources that you can check out. So if you go to my website, I do have a blog. Here are some blogs that if you like these topics and you want more information, and with all of my blogs, I always list all the references and I hyperlink to it. Okay, so the diet called Lymphedema diet goes through what we talked about today with all the research. Anti-inflammatory diet. This is good for everyone, whether you have lymphedema or not, because if you've had cancer or want to reduce risk of recurrence or second primary, you need to be on the anti-inflammatory diet. Ketogenic diet and lymphedema, if you want to read my analysis of that. Intermittent fasting for women over 40. It doesn't matter if you're over 40 or not. It's just a background information on that. And then this last one, how to starve cancer, is sharing research around intermittent fasting and cancer. So it talks about fasting before radiation, before chemo, as prevention, and it also talks about as risk reduction. So read that if you're interested in that. Vanitha is going to send out this PDF to you, which summarizes what Anne Demena talked about last week and what I talked about. So you have that as a handout. And then if you want to hang out with me on social media, then absolutely do that. If you like the subjects that I'm writing about in my blog, then if you want to sign up on my website, then every time I put out a new blog post, then you'll get notification. All right. So Vanitha, I'm going to hand it over to you to handle the Q&A. And
Perfect.
thank you, everyone.
Thank you so much, Jean. That was such a wonderful, detailed presentation, and I'm sure we have a lot of people that are feeling like they've gotten so much information from everything that you went through. So thank you so much for that.
Oh, my pleasure.
Awesome. Okay, so let's jump to the Q&A. So our first question is, intermittent fasting safe for people with diabetes?
Yeah, so from the research I looked at, it is safe. There are certain protocols you need to follow, though, if you're on insulin, especially, or if you're on a sulfonylurea. So any of the diabetes medication that cause your blood sugar to go low, you definitely need to work with a healthcare practitioner. Because, of course, if you're not eating and you take the same amount of medication, you could go low. If you're on something like metformin or other drugs that don't cause a low, or if you're just, a diet-controlled diabetic, then it's certainly safer, at least in terms of the risk of low blood sugars. So yeah, I've seen good success with that. I have a client on insulin, actually, who's been able to, reduce the insulin, lose weight. Because the thing with diabetes is, it's a disease of insulin resistance, and that means you have a lot more insulin circulating in your blood, or you're either taking insulin, right, by injection. If you have high levels of insulin, it's really difficult to lose weight, because insulin is a hormone that tells your body to store nutrients, store fat, build protein. So it's difficult. So yes, it's safe, but I hate to put that out there, and I don't know who's receiving this information and how, competent you are with measuring your blood sugar and interpreting that. So I would really feel much better if you're working with a healthcare professional.
Thank you for that. And so our next question, I think we have a couple of questions on the books that you mentioned, or your book personally. Is there a website that they can purchase that book off of, or?
Yeah, so if you don't mind, I'll just go back to it.
Yeah.
So the Essential Cancer Treatment Nutrition Guide and Cookbook is available on my website and at bookstores. Same with the Complete Lymphedema Management and Nutrition Guide. This one is it's a 4-page guide. In fact, I can show it to you. So that's only available on my website. And then this book is only available now for pre-order, because it doesn't come out until November. So yeah, my website, or any place you buy books.
Okay.
And my website is, right here, just my name, jeanlamantia.com.
Perfect. So our next question, does the autophagy created by fasting destroy or protect cancer cells? And the second part of this question is, what is the minimum length of time for intermittent fasting to get results?
Well, you're on top of it. You are on top of it if you're asking me about autophagy. Wow. And so read me the question again, please.
Does the autophagy created by fasting destroy or protect cancer cells?
That is such a great question, but I can't answer it, because I feel like we just don't know enough. And let me tell you, it kind of scares me. It does scare me, that whole autophagy piece. So if you go on my website and you read that blog called How to Starve Cancer, which is basically my blog on cancer and intermittent fasting, you'll see that there is evidence to support fasting before chemotherapy, before radiation, and as prevention of cancer. However, if you know you have cancer and you're doing fasting, there is some indication that might actually be a risk. And the risk is through that process which you mentioned, which is autophagy. And so for those of you who haven't heard that word, so you can break it down. So it's basically autophagy, and phagy means eating, so self-eating. And after you fast for a long period of time, the body's like, where's the protein, man? I need some protein. So then it starts to recycle protein. And this autophagy has been credited, for example, if people lose a lot of weight, and normally they would have a lot of loose skin, but if they lose it through fasting, then they don't. And autophagy is credited with kind of basically recycling that loose skin and using it for protein. But if you go to that blog that I posted, at the very bottom, there's a bunch of links. And one of the links is to a podcast where these two experts on intermittent fasting and autophagy discuss for 2 hours this whole autophagy and cancer question. And that might enlighten you a bit more. But I don't feel comfortable saying, if you know you have cancer, like if you have metastatic disease, it's okay to fast. I don't feel comfortable saying that, because I just think we don't know enough about autophagy. However, if you want to do fasting, you can certainly keep your fast shorter, so then you're not getting into that autophagy. What was the second part of that question, Benita?
What is the minimum length for time for intermittent fasting to get results?
Oh, I think that's going to be trial and error. And it kind of depends on where you're starting from. So right now, if you're eating from 6 in the morning till like 2 a.m., then, you just scale that down. It's really all relative. And what you do, it's just trial and error. You start with the 12-12, If you get results with that, keep it there for a while, and then move to, 13, 11, etc. So it's very individual.
And to everyone who did join us today. I hope that this session did provide some support to you, and we do hope that you are able to join the next week's talk, which is the third and last part in this lymphedema series, and the recordings will be uploaded as well online if there is any content that you do want to revisit. So I think with that being said, we will wrap up today's session, and just a final thank you to everyone who did participate and present today. Thank you so much.
Can I just add,
Yeah.
join the LAO, right, Tony?
I won't say no to that suggestion. It's only $30 a year for members, for patient members, that is. Only $30. Money well spent.
Yeah.
Alrighty. So thank you so much, everyone, and I hope everyone enjoys the rest of your day. Take care, everyone.
Thank you, Vanitha, and thank you to Wellspring. Bye,
Thanks,
everybody.
Jane. Thanks, Tony.
Bye-bye.
Thanks, everyone.